Screen. Okay, good afternoon, everybody, and thank you for joining us in our next edition of our CFF Town Halls. Today's presentation will be recorded, so we'll share that with the CF community after the meeting's over. Just a quick reminder, if everybody would remember to keep their lines muted until the question and answer session, which you're free to then unmute and ask questions or submit your questions using the chat feature, and we will do our best to get to everybody all today. So without further ado, it is my pleasure to introduce Dr. Kim Watts, the Director of the CF Center at Advocate Children's Hospital, and Dr. Manu Jain, the Director of the CF Center at Northwestern Memorial Hospital. So with that, I will go ahead and say thank you again for sharing your information today, and I'll turn it over to Dr. Jain.
Thanks, David. As you know, we're living in an unprecedented time, and it's required us to do things in sort of an unprecedented fashion. And one of the things that we're doing in response to the pandemic is telemedicine. Now, in point of fact, telemedicine has existed for a long time in various different contexts, whether it's tele-ICUs, where somebody can monitor an ICU, a remote setting, or in rural areas where you can get access to healthcare, even if you're not near a hospital. But now, given the concern about infection control, we are doing more and more of our normal visits as a telemedicine visit. And I was just going to start with some sort of pros and cons and give you my thoughts on it, and then we can open it to questions. I'll see if Kim wants to add anything before I get into the telemedicine pros and cons.
No, I think we're good. Dr. Jain will move on later.
Okay. So, this concept of telemedicine, refers to having a visit with a patient remotely, whether it's just with a telephone call or a video visit. The idea is that you're able to communicate with somebody without physically being in their presence. And there are certainly pros associated with telemedicine. I mean, obviously it's very convenient. As many of my patients have told me, driving into the city, downtown Chicago is not the easiest. Parking, traffic, the stress around that. And so obviously it's a lot more convenient if we can just chat by phone or by video, however we choose to do it. There's a cost savings involved as well. I think it's fairly straightforward. If you don't have to have patient rooms, cost for the patient in terms of driving and parking. So there's obviously a cost savings. Another potential advantage relates to access to subspecialists. We often have to bring in some of our colleagues to help with the care of our patients, and sometimes it's not the easiest thing to get into to see them. And with the option of televisits, the access to subspecialists, whether it's ENT or endocrinologists or what have you, might be a little bit facilitated if we could do a televisit. And in some ways, patient engagement may be enhanced. We could do more often. The visits could be more frequent and more often. Patients could take the lead in reaching out. And issues related to just how invested patients become could lead to patient engagement. And associated with that, there may be improvement in care quality if we're able to interface with our folks more regularly and get a sense of how things are going. We may be able to intervene more quickly as opposed to waiting to see them in clinic on a regular basis. Now, those are some of the pros, and I'm sure there are others that I've left out, but it's not necessarily seamless. There are cons associated with telemedicine. Obviously, it requires equipment, which may not be accessible to every one of our patients. Requires some technical training. Now, with young patients, it's not a huge issue, but with my other older patients who may be less or more facile with social media and accessing the internet, the technical requirements may be difficult for them to able to do a televisit effectively. One of the things that can also happen is patients can, because they have the access to telemedicine, can do sort of an on-demand kind of care where if they have a question, they can go on the internet and find somebody who can answer their questions, but that may reduce the continuity of care aspect of patient care, where you have a longitudinal relationship with patients. Now that's less of an issue, I think, in CF, where everybody comes to see the team on a regular basis, but in other contexts that may be a con. And then, just the idea of seeing a patient and being able to chat with them on a face-to-face basis. It reduces a little bit of a personal touch. Obviously, not being able to do a physical exam, listen to their lungs, their heart, examine, other aspects of the physical exam, and there is that personal touch which is lost. But if we're going to use telemedicine. Next slide. Okay, I think that was the comments.
You have your pros and cons to CF telehealth is up now.
Oh yeah, I don't. Oh, let me see if I can pull that up. Okay. Additional pros related to CF. Obviously, we are very cognizant of infection control, but as good as we are, not physically coming to the clinic obviously is going to be more effective in terms of infection control and transmitting various pathogens, whether it's pseudomonas or viruses, what have you. So there's that specific aspect of CF care, which may be a pro for telemedicine. And then something I alluded to earlier in terms of adherence, if we're able to interface with patients more regularly, more frequently, we may be able to troubleshoot if patients are having trouble doing their treatments or therapies, can't get their medications. A more timely intervention might be able to improve adherence to whatever therapies we're asking our folks to do. Obviously, if you're not coming to clinic, there are some things we can't do. We can't do regular spirometry in clinic. Obviously, this is an important way to monitor pulmonary function, which is something that we feel is very important. Now that may be mitigated to a degree because we are starting to use home spirometry, and our patients who are able to do this, we can monitor pulmonary function that way. It is difficult to get respiratory culture. It's not impossible, but getting regular sputum culture, especially in the younger population, is an important part of CF care. Which is not to say that it's not important for adult patients as well, because we can get them on a regular basis as well. But that really requires bringing the samples in to clinic. And then with CF, it's a team approach, and getting everybody on a televisit is not necessarily seamless. There are ways to do it to have all members of the team involved in the care of CF patients. We obviously feel that every member of our team brings an aspect of care that's important, and coordinating all that, it requires a little bit of planning and troubleshooting, but it is something that we have to look at and overcome as we go and continue to do our telemedicine care. And I'll finish by saying that I think telemedicine is here to stay even when we get out of this pandemic. I think that depending on how the payer landscape evolves, I think we are going to continue to do telemedicine going forward, and sort of having a hybrid approach where we do some telemedicine and some face-to-face. How that will exactly look, I can't say at this point, but I think that is something that's going to occur more and more frequently in the future. And so with that, I'll stop and give way to Kim and any other questions. Thank you.
Thanks, Manu, and thank you to the CF Foundation for having me today. When I think about what it means to do virtual visits and what we've learned so far, serves in four main categories. But the first one I want to talk about is what having the electronic medical record and what having access to video visits means. It means right now that we were pretty seamlessly able to shift or pivot to video visits in place of the clinic visit. And that's what, during the pandemic, that was how this started and was mandated. And that was great. And what we learned from that was that what's the best way to run a multidisciplinary clinic like a CF clinic in a virtual capacity? How can we get all the providers in, and how can we actually reduce our risk to not only the patients but to healthcare providers? So what we did was stagger our clinics so that part of the team was in person and part of the team was at home. We've had doctors staggered of one in-person clinician and one remote clinician. And that's really allowed us to be real flexible about how we're seeing our patients. And what we can do with those video visits then, if it's done well, is to try, just like Dr. Jain said, is try to patch all the members in together. And this allows us to see the patient to see the entire team either together with everyone's Zoom picture up there or in series. And that's been really a game changer for us. And I think that that is something that'll be here to stay. It's being able to see the patients all in one space, meaning that all the providers in the room at the same time, I think might be a great opportunity going forward to how you could sort of have a state of the patient with all the team and the families, the patients all talking together. It's just something that we hadn't really done in the past that might be a capability that we could grow on with telemedicine. We've had a lot of questions from families about what does this mean to frequency of visits. Obviously, during the pandemic where people were asked to not come into clinic, we were using them, like I said, in exchange of an in-person visit. But we're trying to figure out as clinicians how we're going to look at this going forward. Everyone understands that there needs to be inpatient clinic visits, but how can we augment our inpatient capabilities with virtual capabilities? So, and is there a one-size-fits-all approach? So maybe we have patients who live hours away that struggle to come into clinic. Can we split their visits virtually and in person? Can we do a by risk assessment, patients that we really think need to be in person more often, and then other patients that maybe could do more virtual visits? So I think there's a lot of different ways to approach that. The way we're looking at it right now is we really want to make sure that not only do we see our patients in clinic or virtually, but that we can use the virtual visits to augment those scheduled visits. Can we use them for sick visits? Can we use them for nutrition follow-up? And there's just some creative ways that we can use that where we weren't able to really have as many touch points with the families and patients before. Dr. Jain alluded to the monitoring at home. And so that's really one of the linchpins of this, and how this is all going to come together is how much monitoring can we do at home. So the CF Foundation has been very proactive in getting home spirometry devices to families and to clinics to disperse to our clinic patients. We're getting great results with even kids. They're practicing on them. They're able to practice on them more frequently, so that when they do come to clinic, we're more confident that their technique is better than it would have been if they only tried every 3 months. So we think that this home spirometer is a great addition to CF Clinic, and it's been really one of the silver linings of this. Also, at Advocate, we are part of a research project right now where we're working on home exam devices. I know other hospitals have used these as well, where we actually can use a smartphone and a small apparatus to do some basic exam skills. So heart and lung and ear, nose, and throat. That's just something that we're going to be trialing to see if our patients like that, to see if that's helpful for everyone. And then I think the fourth thing is about what are your local capabilities. So families ask questions like, well, where can I get my labs done? Where can I get my culture done? And so I think we have to have a pretty open dialogue with families and patients about that. On CF patients who can expectorate, and if we give them cups and they can bring them to a clinic that is able to do CF cultures, that's a great option. Obviously, on some of the kids who don't have productive coughs or unable to do that, we successfully have trained some families to do the swabs and have gotten results that we think that are true results. So that's just about educating families and seeing what we could do and making sure that people are going to the right labs, utilizing the right resources. But that's where we can really partner with some more of our local lab counterparts to see how we can bring care back closer to the families if they're not going to be coming into clinic, or if there's a reservation about coming into the hospital. So I think there are a lot of silver linings for during this time as it pertains to virtual visits and telehealth. And I think cystic fibrosis has been on sort of the leading edge of a lot of different things clinically. We know that, and I think it's very prime and poised to do this for telehealth as well. And I think that if we can, even if we really do still want our patients in every 3 months to get their evaluations as the CF Foundation guidelines recommend, we'll always now have this opportunity to do virtual visits to either work more closely with the families or patients, or to be able to augment their care, which I think is very exciting. And as I agree with Dr. Jain, is going to allow us to have improved quality of care for our patients. So I think that's all prepared I had. David, if you want to go to the questions, that'd be great.
Yeah, we had a few questions that were submitted through registration, so I'll let you kind of decide which ones each of you wants to field. But the first question is, my biggest question is, how long can a child with CF wear a mask safely before bacteria starts to develop, and they are now breathing in all the bacteria?
So I guess I'll start with that one. It's amazing how good the CF kids are about wearing masks. It's really amazing how quickly they've adopted this, and we're very proud of them. It's just one more thing that they have to do, but they've done a good job. I think that, a CF patient, if we're talking about what specifically there is a concern for CF child wearing a mask versus someone else wearing a mask, I think I'm understanding that question. I went through this with Manu before, is that the concern is that what they're breathing on the inside of the mask, not what's on the outside of the mask. If we talk about what's on the inside of the mask, that's what patients are breathing from their own respiratory tract, and that is their own flora. We know that in cystic fibrosis, I like to explain it as the bacteria that are in your lungs are sort of the ones that you live with. And when you have an exacerbation, the balance of that goes in their favor. But we know that there's different bacteria that reside in the CF lung that sort of CF patients live most of the time with symbiotically. So when they're breathing that out into the back of the mask, my thought is that they're breathing their own bacteria that they have in their lungs, and that they're breathing it then back in, and that's what's in their own lungs. If you're talking about the outside of the mask, when you're in situations that are, say in the hospital situations, and you're talking about how to apply and take off a mask, the discussion about not touching it here, but taking it from here so that you're not touching whatever's on the outside is the recommendation. So I think that would be for all people. I have 4 kids myself. All of the masks smell within an hour. So I think it's really about, washing the masks. If you're going to use the reusable masks, just wash them as much as you can, just because for nothing else, they sort of start to smell and look dingy, and that's not going to help anybody with any of the issues that they're worried about for infection. The disposable masks, I think one of the things we have to think about with those disposable masks is that people are wearing those disposable masks multiple times. And I think that's something that we need to really consider. They're not really meant to be worn for days on end. And so I think that the most conservative thing would be to wear the reusable masks and wash them often. And if you're going to use the disposable masks, which now are more available to non-healthcare providers, just throw them out after the day when they're done. They shouldn't be reused for days on end. I don't know if Dr. Jain has any more to add on that.
No, Kim, I agree. I mean, I don't, the surgical masks or the wet masks you wear in clinic are designed as one use. And so, they stretch into the pores, are not quite as small as they are after they stretch for a while. So they shouldn't be used for more than one day at a time. Now, that being said, I think during the pandemic, certain situations, people use them for more than one day. That's obviously not ideal or recommended. But I think once a day for the disposable masks is right. And then I agree with the washing. I think at the minimum every couple of days is probably a good thing to shoot for, or more often if you can do that.
Awesome, thank you. The next question is, having a child with CF, I do not feel comfortable coming into the hospital where our clinic is located. How do you recommend getting all of their labs completed? Home nursing, possibly? This particular person has been trying to get this done since May, and her daughter has not been able to get her labs and scans completed.
There isn't a good solution. You know, I think that anytime you're exposing your child to somebody who has not been in the home, obviously there are certain risks associated with that. Minimizing that risk is associated with minimizing the number of people that they're exposed to. So if you are able to arrange home nursing to have a blood draw done at home, assuming that, you know, the nurse will wear a mask and has been tested or at least been screened for not having COVID, that might be the safest way to go. Now that being said, we have a fair number of patients who are getting their blood drawn in the hospital, but it really comes down to an individual's, comfort level in terms of the risk they're willing to accept. So there's probably not one solution that fits all, but if you're able to get home nursing, that might be the safest thing possible. We've certainly done that for some of our research visits, and that seemed to work okay.
I think that for the thing to remember about that is that the conception that, or the misconception that the hospital is more dangerous than the grocery store. I think if you're, and we've said this, we will work with whatever our family's level of comfort is. We have families who haven't left the house since March, and we have families that are going back to school in person. And so it's really about talking to your healthcare team about what you're comfortable with. There are outpatient facilities to get labs done and scans done that are not embedded in the hospital. Like I said, these are some of the more local agencies that are closer to homes or are just outpatient satellite facilities. That's a discussion about would families feel more comfortable going to a place like that where you're not going through the main hospital doors. I know sort of at our hospital, our outpatient lab are separate than our inpatient lab, so it's almost looks like an outpatient satellite. Hopefully families will be more comfortable with that. But I think what's really important is that families and patients realize that hospitals are doing every single thing they can do to provide safe care. And they take this very, very seriously. And there's screenings at every door, and people are masked all over the hospital, and all the appropriate PPE is being used. And so I think that as opposed to early on, where we told everyone to stay home, we're now in a phase where we have the equipment that we need, we have the protective equipment that we need, we have processes in place. It's okay to be in the hospital. It's okay to go into a healthcare environment to get the things you need. We don't want to delay care. There was a chaotic time in the beginning. That is all, in my opinion, stabled out, become more stable as far as delivery of care goes. And I think that I would feel comfortable and have felt comfortable bringing my own children into the hospital. We've had pretty good luck with bringing our CF patients back in. CF, like I said, has always been a leader in infection control anyway. And so I think it's about having that conversation with your healthcare team about what options there are for you from an insurance standpoint, what options are there for you from an environment, from a location standpoint, and then reassurance from your healthcare team about what we're able to do in the hospital or clinic setting.
One of the things that I do want to mention is that if you're getting blood done locally, most blood testing are CLIA certified, and the tests are transferable. It is a little bit different for sputum cultures. There are certain methodologies that CF accredited centers use to culture CF sputum. And so you may want to make the extra effort to get the sputum culture done by your local CF center, because the laboratories are specialized to culture CF sputum specifically. And so there is a difference between blood work and sputum cultures.
And what we found that some of the parents have wanted to do is the parents aren't concerned about coming into the healthcare facility. They're concerned about the patient coming into the healthcare facility, the child. So we give them the tools, they get it from home. The parents don't have any trouble running into the lab and dropping it off. and I 100% agree with Manu, it needs to be an accredited center. So sometimes the parents are running that in, and that's been helpful to them, because the fear is having the child into the environment, not to the parent. So that, again, you work with your team to make sure we don't want you doing any of your things where it wouldn't get the appropriate evaluation.
Great, thank you. Somebody had entered CFRRT in the comments field. I'm not sure exactly what the question pertains to. So
Manu, I thought this was probably someone asking how they're going to see the respiratory therapist. If we're telemedicine, that's what I thought it was. What we've done is actually the virtual visits has been very helpful for our respiratory therapist. And I think everybody probably does the same thing. We get to see actually what's in your home. And so our respiratory therapist has been, can video visit in with families and actually look at the devices so that the vests aren't getting carried to clinic, and we could check on the status of the neb machines and things like that. So I think that's actually been an asset to the video visits for the respiratory therapist. And then I think we spoke already to what does it mean for cultures, where you have to be thoughtful about where you're bringing these cultures. And then spirometry, I think the wave of the future is going to be home spirometry. And with the product that the CF Foundation's endorsing really is a great product, and we can, it downloads right to the clinics, and we can look at the technique and the trials, and it's been a very exciting innovation. So I think things are good from that standpoint. And I think as long as the respiratory therapists have the capability to do video visits, that would be a good thing going forward for the families to continue to cultivate a relationship with them.
One of the things I will say about home spirometry is that, I think it's going to be a significant change in how we track pulmonary function. But one of the things we're going to need to do is verify that the values that we're getting at home are close. They don't have to be exactly the same, but that they're close to things we measure in the PFT lab in the hospital. So at some point, it'll be, I think, important to provide a sample of, do a home and the hospital spirometry, just to make sure they're close, so we understand that they're correlating pretty closely, so we can really have confidence in the home spirometry measurements that we're getting.
Right. Well, when we're encouraging people to come back into clinic, what our respiratory therapist is trying to do is have them bring their home spirometer to look at the technique. And then as we start to reinstitute spirometry in the clinic, really, like as Dr. Jain said, really make that correlation. We've had some inpatients who have showed very good correlation between it. And I think that's going to be that's going to be in the future. We're going to see what that looks like, but the initial findings look pretty hopeful, but I agree with Dr. Jain 100%.
Great. And the last question that was submitted online is, I'm curious if you're able to address how patients through telehealth are monitoring and collecting sputum for PA monitoring. How will you teach or train on a new device?
Well, I think we alluded to this a little bit already, that collecting regular sputum is obviously important, especially when you're screening for the first Pseudomonas infection. And what we've been doing is providing sputum cups. We're able to mail them to the patients, and once they're able to provide samples, those can be brought in and either by a family member or a parent or someone to bring the sample in, and that can be cultured and that can be turned around in a fairly expeditious way. And so that's how we've been monitoring for Pseudomonas infections or other infections in our patients. And then how will we teach and train? I think it's going to have to be a hybrid approach. I think that whenever we implement something new, I think there are obviously ways to do it electronically, and with a capability of video visits, you can do sort of step-by-step approach as you are being trained. A speech therapist could watch you and help you do it, and then this could be supplemented when a face-to-face visit occurs. We can certainly go over the same techniques to make sure that things are being done properly. So I don't anticipate that the teaching or training aspect is going to be a significant challenge. In some ways, if we could reinforce things more frequently, but via televisits, we actually may improve techniques and improve adherence in that way.
I think that one of the most important things, and I'd like to hear what Dr. Jain has to say about this, is what I think we're going to come up against is as the CF population gets healthier through newborn screen, through genetic modulators, the concern for the clinical community is the pushback of, I don't want to come to clinic anymore. That was already starting before the pandemic. And so that message that the team has to provide about what value we're adding in clinic, what the visits, the in-person visits can provide, what the virtual visits can provide, it's just important for us to think about going forward, because the disease is changing and the expectations of families and then adult patients is changing. And I think that we need to sort of take that head on, because as I said, we were already hearing that people, why do I have to come every 3 months? I'm on genetic modulators, my lung function's 100%. The highest risk place I go is CF clinic. You tell me to stay away from everybody with CF. Now you want me to come to clinic when I'm already doing well. And so I think that the CF community sort of addressed that head on. And I think that the implementing or partnering with the telehealth function is going to be one of the ways that we can do that.
Yeah, no, I agree. I think the quarterly visits are done because that's what the guidelines from the CF Foundation recommend. But those guidelines were developed in an era when you had more exacerbations. We didn't have modulators. We didn't have a lot of the even airway clearance modalities that we have now, like even pulmozyme or inhaled antibiotics. And so, I think that it is clearly on the radar for the CF Foundation that these guidelines are going to need to be revisited, because CF is evolving right in front of us. It's evolved in the last 5-7 years, and it's going to continue to evolve as some of these modulators get into the younger age group. So, I think that's what I was sort of alluding to when I said I think televisits are here to stay. And what the right mix is going to be is, I think, still up in the air. And it may be that it's different for different people. Some people may still require quarterly visits. I expect that's going to be a minority of people. And some people may require visits every 6 months or a year, who knows? But I think we're going to have to be flexible in terms of how we look at patients. And I expect the guidelines may change over the next few years. And so it's something we're going to have to watch out for. But I agree with Kim. I think we're going to have to meet that challenge.
Great. Thank you both for answering those pre-submitted questions. Now, I think we'll turn it over to our chat feature to see if there are any questions that may have come in online. I don't see anything in the chat feature, so feel free to unmute yourself if you have a question that you'd like to ask either Dr. Jain or Dr. Watts. Okay, well, it looks like we don't have any additional questions coming through from the audience. So with that being said, is there anything either you'd like to say in closing or?
Nope. Everybody have a good day.
Awesome. Well, thank you all for making the time to attend today.
Oh, question just came in.
Oh, perfect. Oh, talk about reimbursement.
Well, I take that to mean reimbursement from payers for televisits. Is that the question?
Correct.
Yes.
Yeah, well, so it's unclear. I mean, obviously, Medicare and payers have made a special consideration during the pandemic I think this is something that's going to evolve over time. One of the driving forces of face-to-face visits is that you couldn't get reimbursed for televisits previously, and so there obviously is a financial pressure to see people in public, in person. But I think that given what we're learning about the effectiveness of televisits and monitoring, that has to be looked at. Unfortunately, that's a little bit out of my control and Kim's control, but as caregivers or practitioners, we're certainly open to having a hybrid approach because we think it actually could improve healthcare. But financial pressures are there, and so we'll have to kind of see how things evolve over time.
And if you don't mind, if I can chime in to see if on the line or on the call is Dr. Kathy Webster, who's the head of telehealth for Advocate Children's, and she's been really helpful in helping us all understand what it means to do telehealth visits from a clinician standpoint, but also from a provider standpoint as far as reimbursement goes. So Kathy, do you have anything to add on that?
Sure. Thanks everybody for letting me join you today. It's always interesting to hear everybody's perspective on telehealth in these situations. But in terms of reimbursement, what we know is that a lot of it is going to stay. So what we have for fact is the CMS proposed rule for 2021. And while that applies to Medicare, we know that many of the payers will follow those guidelines. So we do think that particularly home as a site of care is going to continue to be recognized, which was a big barrier before. We are pretty hopeful that that's going to continue to remain on there. I think one of the things that is really important with all of this is that we continue to collect data. We've been given an enormous opportunity to do sort of a giant research study here where we've had 6 months of televisits that were sort of forced upon us. And if we can look and prove the outcome to this and prove that we aren't increasing costs, that we're saving costs, we can do some kind of analysis around that. That's really going to help us continue to make the case moving forward.
Thank you. One additional question came in. I haven't been using a spirometer since being diagnosed around 2 years ago. Will I need to start using one?
Well, I think that I wouldn't necessarily need. I mean, I think you get useful information potentially. And I think we're going to have to individualize how often people need to do spirometry. I have certain patients that I would love to get weekly spirometry. Other folks, I think doing it on a quarterly basis would be fine as well. There is a risk of having too much information. I think that, if you do it on a too often of a basis, that there is some sort of day-to-day variability that we normally expect that, might create some confusion for patients. So I think that going forward, this is a discussion that I've been having with each of my patients who will have a home spirometer with respect to how often they need to do it, what are the parameters in terms of calling and saying, hey, this is what's happened, do I need to do anything about this? And that's going to be obviously an individualized discussion we're going to have.
And the CF community has struggled for such a long time about defining what a CF exacerbation is, right? Every different center has their own flow sheet that they put out and the tracking mechanisms that they use. And I think that the home spirometry is just another way to sort of define what an exacerbation is. We do know in kids, understanding the day-to-day variability is difficult. We don't want panicking teenagers because their lung function is down by 1% or 2%. So again, I agree that it's really that finding the fine balance of information and also using it appropriately. And I think it's about all of this is really about stratifying risk, whether it's how often you're using the spirometer or how often you're coming to clinic. Because CF has changed so much, it's probably time for us all to get together. And I'm sure the CF Foundation is on the forefront of their minds, and really start stratifying risk and figuring out what the guidelines are going to be based on what risk factors you have. We have to remember that there's still about 10% or a little bit of the population that's not going to have a genetic modulator. Are their recommendations going to be different than everyone else's? And so, or someone who's been late diagnosed versus early diagnosed versus a newborn screen. So I just think that that's all part of the puzzle. And it's just this, again, whether it's home spirometry or video visits, it's just one more tool in the toolbox that we have to take care of the patients. And so, like we said, if there's anything of a silver lining of all this craziness, this would be it.
Awesome. Well, looks like that is about all the questions. So thank you again to Dr. Watts, Dr. Jain, and Dr. Webster for chiming in and sharing this important information with the CF community. And thank you all for taking time out of your day to join us today. We will be sending out a follow-up email with a recording of the videos. So if you didn't catch all of it, you'll be able to catch up there. But stay tuned. We have several more town halls scheduled for the upcoming months. One is going to be focusing on our Compass program and a few other topics that will be launched soon. So keep an eye on our social media for the CF Chicago chapter Facebook page is usually the latest and greatest of what events and virtual events are coming down the pipeline. So thank you all again. And without further ado, I'll give you back some of your time to enjoy your lunch break. So thank you.
Thank you.
Thank you.
Well,
Thank you.
bye.
Bye-bye.